So I'm going to talk today and update you on progress about our research of a cell called DUOC version 1, which is a cell that can promote myelination in the brain. And I'll discuss a little bit about our clinical trials in children with leukodystrophies and more recently adults with multiple sclerosis. These are my disclosures. So we developed DUOC because we observed years ago in a collaboration with Evan Snyder that cord blood definitely engrafted in the brain of a child with Krabbe disease who unfortunately had symptoms when we transplanted her and who died 10 months post-transplant. But because this child was female and her donor was male, we were able to look at XY fish in multiple areas of her brain, and one picture of cortex is shown here. But all the green dots are Y chromosomes in donor cells engrafted in the brain, and this was 10 months post-transplant. And this, of course, was an intravenous transplant of umbilical cord blood after myeloablative chemotherapy, the standard way a transplant is done. When we looked at what the cell was, these cells were mostly microglial cells. And through work we've done over the past 10 years, we've shown that they're derived from the CD14 monocytes in cord blood. We developed methods to grow DUOC in a GMP environment so that we could take it into clinical trials. And it grows as an adherent macrophage-like cell in 21 days. The cultured cells express CD45, CD14, 11B, and importantly, as you've just heard, TREM2. This is just a picture of time-lapse photography of the morphology of the cells as they grow in culture. We use both their phenotypic and molecular signature to mark them and characterize them in culture. We've done a number of studies, and most of these are published, showing that these cells in murine and organotypic systems can remyelinate damaged or brain that is damaged by demyelination. In the case of this slide, this is an experiment with a system called cuprazone, where mice are fed cuprazone, which is a copper chelator, in their diet for 5 weeks. They then demyelinate the corpus callosum. You can stop the cuprazone and then look at rates of remyelination. And we did several experiments showing that if we injected DUOC into the brain parenchyma, that we saw remyelination of the brain within a week of stopping cuprazone. So the top panels show the control mice where the vehicle we put DUOC into was injected. The bottom panel shows the DUOC mice or receiving mice. And through Luxol Fast Blue and DM, you can see that the cells remyelinate. The quality of the myelination is normal, and there's no reactive astrocytosis in the cell-treated mice. We also showed that this was really secondary to promotion of endogenous oligodendrocytes that were induced to proliferate by DUOC. So the DUOC cells don't directly myelinate, they induce endogenous oligodendrocytes to myelinate. We published the characterization of this cell through help with David Wenger. We were able to show that manufacturing did not interfere with the cell's ability to produce lysosomal enzymes as long as they came from a normal donor. They have macrophage functions as well and can clean up debris. They also modulate inflammation by secreting IL-10, IL-6, and TGF-beta. So I showed you they drive oligodendrocyte proliferation, and that promotes myelination. They have a molecular signature, which is shown in the table on the right, and which again we use to characterize the cells after manufacturing. We also looked at these cells in an experimental autoimmune encephalitis murine model. This is a model many investigators used to study multiple sclerosis. And in this model, mice are injected with tetanus toxoid, which induces an ascending paralysis. We established the colony in our laboratory, and then characterized the course of disease. Just to know, these mice are scored for paralysis on a scale from 1 to 5, with 1 being early symptoms, the first of which is a limp tail, and 5 being a moribund animal. We then followed cohorts of mice that we injected intrathecally, really into the cisterna magnum with DUOC cells when they had a score between 1 and 2, so that we were sure they were developing paralysis, but they were not so sick that they were moribund, and followed them for weeks after. And what we were able to show in the blue and the green dotted lines is that after injection of DUOC, the pace of development of ascending paralysis changed and stabilized. And the mice did not progress further. And that was compared to control mice who got Ringer's solution, which is what we suspend the cells in for injection, or Ringer's with hydrocortisone, which we added to our final formulation. And I'll explain that to you in a little bit. We also showed in this model that one of the ways DUOC might have been working was to reduce lymphocyte and specifically T cell infiltration into the spinal cord of the animals with progressive disease. You all know that in Gravet disease, most children develop progressive peripheral neuropathy as they get older after transplant. And these 2 girls, both of whom were transplanted at Duke and both of whom were also studied by Maria Escolar when she was at UNC, had transplants in the first month of life. Maria looked at their corticospinal tracts by fiber tracking at 2 days of age. And she was able to show that the little girl on the right already had damage to her cortical spinal tracts at 2 days of age, which says to me that, no matter how early we go, it may not be soon enough, and we need some restorative therapies as well. And as you can see, this child with the damaged tract at about 8 years of age was already having trouble walking, and that has progressed as she has gotten older, whereas the child with less damage and a pretty normal looking tract at 2 days of age is much more functional as a teenager. So we developed DUOC as a cord blood derived cellular therapy with the intent that we would give it intrathecally after a standard cord blood transplant to accelerate delivery of cells to the brain, hoping to induce some repair of damage to retrievable tissues and prevent disease progression. As I mentioned, DUOC's manufactured from a cord blood unit. Initially, we did it from a 20% fraction of the cord blood unit. I'll show you a picture of that, where we split the unit, and the bigger portion of the unit was used for the standard transplant. The smaller portion was used for DUOC manufacturing. That meant that the patient was tolerized to the donor before DUOC injection, which was administered roughly 4 to 6 weeks after transplant, after engraftment, and in patients who did not develop graft versus host disease. The eligibility for phase 1 trial, which has been going on now for 7 years and is really completed, but we've kept open for expanded access, was children and babies with known lysosomal or peroxisomal storage disorders that could be treated with cord blood transplant. Ages 1 week to 21 years with neurologic evidence of disease, standard qualifications for cord blood transplant. And unlike cord blood transplant, where typically we would require a Lansky of over 70. Here we allowed Alinsky over 40. So we did allow children with more symptoms to come onto the study. We also learned that, that not every cord blood unit yields good growth of DUOC cells. And in fact, roughly 70% do grow DUOC, of which about 10% grow very robust DUOC and others grow modest DUOC, and 30% don't grow DUOC at all. And so we developed a scoring system where we could screen units not only for the standard things like confirmatory HLA typing, but for DUOC growth in small, tighter dishes, and then select units that would grow DUOC. And in our current protocol, we use 1 unit for the transplant and 1 unit for DUOC, and both have to match at least 4 of 6 HLA loci, both to each other and the patient. The DUOC unit has to score positive in this screen. The transplant unit has to have standard potency for hematopoietic cell transplantation. The protocol involves conditioning, use of either a whole cord blood unit or the 20% fraction to grow DUOC, which is started a week out from transplant, and then administration of DUOC between day 28 and 42 post-transplant, assuming the patient is engrafted and doesn't have GVHD. Patients are followed with a CT scan of the brain 2 weeks post-DUOC. FDA asked us to add that for safety. And then MRIs at day 100 and 1 year, CSF studies at day 100 and 1 year, and then the standard follow-up post-transplant of neuroimaging and neurophysiologic and neurocognitive testing. DUOC is grown in the laboratory over 3 weeks under GMP in a clean room. Cord blood unit is thawed, washed, red cells are removed, and the cells are plated. They're grown in proprietary media that is a growth media for the first 17 days and then a proliferation media for the last 4 days. And when they're harvested, they have to pass release testing for viability, cell count, sterility, which is future, but is tested along the way, and then a real-time gram stain, endotoxin, and then later mycoplasma testing. Current status is that we enrolled 40 patients in this study, 30 of whom received DUOC. Of the reasons that the 10 patients didn't receive DUOC included 3 who had graft failure, 4 who had treatment-related mortality or morbidity with GVHD or other infections, and 3 where the product from the 20% fraction failed manufacturing. Of the patients treated, we gave between 600,000 and 10 million cells. This is absolute, not per kilo. And these patients engrafted in a median of 20 days, which was required for DUOC administration. And you can see the distribution of diagnoses of patients that were enrolled on the trial. We administered DUOC between day 27 and 77, and it was through a lumbar puncture performed under sedation. And we had no adverse events related to the actual cell administration procedure. In the first of 11 patients treated, there were no AEs related to DUOC, no unexpected imaging abnormalities, and no CSF abnormalities. And these patients all received DUOC from the same cord blood unit that their transplant came from. We did in that course, though, have 4 products that failed manufacturing. And we modified the protocol to move to a single unit for DUOC manufacturing, which would be like a double cord transplant, 1 for transplant, 1 for DUOC, both 4 of 6 matching, et cetera. But 2 of the first 3 patients who received what we called third donor DUOC developed fever and hypotension a few hours after administration. These reversed and were gone by 24 hours, but nonetheless, it was different than what we had seen earlier. And we did perform lumbar punctures on these patients 24 hours out and saw a CSF pleocytosis with granulocytes in both patients. It resolved, but we were concerned and we decided to add hydrocortisone to the final formulation, much like one would do with intrathecal chemotherapy. And we validated our manufacturing to show that the DUOC stability and potency were not adversely affected by this change, filed all that with the FDA, and then resumed the study with double donors for the future patients. Actually, we're up to 11 additional patients treated without problems now with the DUOC in hydrocortisone. So really this phase 1 trial is complete, although we're keeping it open. The safety profile is favorable. Really, it's impossible to evaluate efficacy because of the multiple diseases and multiple condition and clinical courses of the diseases that were treated. So we knew that we needed to evaluate DUOC as a single agent in a disease that had valuable endpoints. And so we are now testing DUOC in patients with primary progressive multiple sclerosis in a phase 1A clinical trial. And although I didn't mention it at the beginning, all of this is under IND from the FDA. So this trial is a dose escalation trial for 20 patients who, again, have had no other transplant or related therapies, are progressing with their PPMS symptoms, have a 4/6 matched cord blood unit that produces good DUOC in the screen. And we're giving escalating doses of DUOC to individual sequential patients at 10 million, 25 million, and 50 million cells. And then the endpoints besides safety are efficacy studies, both with functional scores and MRI at 3 and 12 months post-treatment. We treated our first patient last month. We have manufacturing in progress for our second patient who will be treated next week. The first patient tolerated therapy well, but it's way too soon, obviously, to say anything more. Hopefully next year I can show you some real outcomes. We're also working to manufacture or to optimize manufacturing and our characterization and potency protocols so that we can conduct future phase 2 and 3 clinical trials. We're hoping to be able to cryopreserve DUOC, which is not an easy feat because then it would be transportable to other sites for treatment and you could have a single site for manufacturing. We are developing a potency assay, which is related to an organotypic model of oligodendrocyte differentiation. And we're also looking to immortalize DUOC, which would create a master cell line that would be from the line that doses could be derived from. So in summary, DUOC is a novel cellular product derived from the monocyte lineage of cord blood cells. We've established manufacturing for the first phase 1 clinical trial and treated 30 patients to date. We did have initial reactions in 2 of the first 3 patients treated with DUOC that was manufactured from a second cord blood unit, but we've ameliorated that by adding hydrocortisone to the final formulation. We're now testing escalating doses of DUOC in a phase 1A trial of adults with primary progressive MS, and we're optimizing manufacturing along the way. There are many, many people who have been involved in all this work, and many of them are on this slide. These clinical trials and the manufacturing have been supported by the Marcus Foundation. And of course, we thank our patients and their families. So I'll stop there and I'm happy to answer questions.